Later on, proceeded to take a check shot and a non-inflated balloon was required to stabilize the guide catheter. Manipulation of the balloon pulled back the stent further. Stent starts were visible above the guiding catheter. Maybe only one or two stars was in left. So this is the stent you can see over the guide catheter. The stent, most of the part of the stents, there is some 2 or 3 millimeter in the left main. So the heart plug is not alone now. It is even called a party to knock us down. We have 2 challenges. One, to treat the left dissection of the debris, and 2, take the dislodged stent out, which is on the guide catheter. But how? Bewildered, because if you put the second stent to cover the left coronary dissection of this guide catheter, then the first dislodged stent might be caught up, making things more complicated. So made a plan. One, as most of the stent was hanging in aorta over guide catheter, and only a few millimeters is in left main, we'll try to catch it with a 4 inflated balloon and pull it out en masse from the body through femoral root by first guide. The second, again as this left coronary dissection, will take another guide catheter in radial root, stand by, to rapidly pass it back and get control for the left stent But luckily, the misplaced stent moved further down over femoral guide catheter. So the risk of being overlapped by the second stent is dropped. So we decided to use the femoral guiding catheter to stent the left into LAD dissection, as we have the wire already in through. So again, 3.5 millimeter onyx stent from left to ostial to proximal LAD lesion, inflated at 40 atmosphere. A non-inflated 4 millimeter balloon was used to stabilize the guide catheter and take check shot to conclude that second time the stent was placed right and lesion was clear. So left dissection was solved. And then it was pulled in with 4 millimeter balloon. And the last shot of the left system. Now problem 2. How to remove the dislodged stent which is hanging over the guide catheter, XB guide catheter. So guiding catheter was taken back from the left ostia, taking the wire in. Then 4 millimeter balloon was inflated distal to the guide catheter in aorta and put everything en masse back into femoral shape. So the dislodged stent over the guide catheter won't slip out. But to my utter surprise, we were trying to pull the stent in 7 French body shape with inflated balloon. The balloon ruptured. The stent went back to the iliac artery, dancing over the coronary artery. You can see the So now the big long picture of the stent, you can say the stent is dancing over the wire. So another 4 millimeter balloon was taken and inflated distal to the dislodged stent to prevent forward displacement and with an aim to get it into 7 French body shape. Again, we tried to put back the stent into shape, but again, when the dislodged stent was about to enter body shape, the balloon ruptured. Because already the stent is taking size and entering into the body shape. So we pulled the balloon out, changing the 7 French shape to a larger 10 French shape and decided to use peripheral snare to catch it. So catch the wire with the peripheral snare. Then try to pull the stent into large 10 French shape, but again slipped at last moment, but somehow managed to grab again by snare to get it inside 10 French shape. And it was whole life of catching a big fish. Then snare, wire, stain, guide catheter, everything and the master together taken out of the body carefully when the skin is half of them in the condition. The whole system enmasked out and the broken stain by big fish. So take a message. One, coaxial placement of diagnosis and guiding catheter and ability before diagnostic is very important in left and coronary artery to prevent dissection. Two, during osteodisplacement placement of stent, position must be confirmed. Breath holding during inflation after confirming position can be way out. You can also put a second way insert to stabilize guide catheter. Three, to pull out a dislodged stent where excess is not lost, balloon inflation disturb the stent, pull it down in sheath, then take out the entire system, or snaring it down may be a solution. 4. Seek help from colleagues in cath lab nightmares. It is always strong to work as a team. So this is the algorithm for total stent loss where guide were in situ. If you lose a stent in coronary artery, you have to pass a small balloon and like 1.5 millimeter, you have to put 3 atmosphere and try to pull the stent inside the guiding catheter. If fail, and if the stent vessel size is acceptable, then you can deploy it by increasing the balloon size. If not, then push it into somewhere in the branch vessels where the stent size can match, then you deploy. If fail, and if the stent is in the proximal portion, you can try to scan. If not, in the middle portion of the coronary arteries, then you can pass through 3 wires, then twist them so that the stent can get caught in the intermediate wire and bring the 3 wires en masse. And if not, if all this fails, then you touch the stent by another stent in the vessel wall. And if the wire is lost over the stent, then you have only 2 choices. Either you can bring it out by snare, which is proximal. If you can't do it, then you have to turn the stent in the coronary artery wall by putting another stent. So take a message 2. A normal person learns from his own mistake. Fools do the same mistake again and again. An intelligent person learns from the mistakes of others. So be an intelligent person or intelligent cardiologist, unlikely. And take a message 3. If you don't want to have nightmares in cath lab, be prepared. And if you don't want to have nightmares at home, don't forget your marriage anniversary. I forgot once. I have to pay for 1,005 years. Thank you.
Dr. Qasim, can you tell something about the dislodged stand was in oil? But if the stand embolized and if that you lost your blood pressure, then what?
Yeah. I just told you the algorithm. So this is the total stent loss and guide wire loss. So if the stent is in proximal coronary artery, you try to snare it. And if it is not, you fail. Then you could crush the stent against the vessel.
Thank you, Dr. Professor Nasrul. It is almost veterinary professor and it is a very appreciated that the trash is at last filled with the flower. Thank you very much. Any question from our audience?
I have a question. Actually, it is one the marriage day or birthday as well?
Any comments from our audience?
tell us when you start the intervention. If you are using LVO catheter, be careful about injecting the dye forcefully, as because most of the time it engages in a transitional axis with the vessel. So if you push very hard, the contrast media, it may right cross dissection if there is any minor plaque at the ostium. And the same thing happens with the M+ catheter. Thank you.
You can give a big hand to Professor Nasrullah Khan for a brilliant presentation. Now may I request Dr. Sanjay Karla to give his talk. He will give lecture on donor vessel thrombosis, a managing disaster.
Okay, thank you very much. I'm going to keep this fairly tight in consideration of time. And so the majority of this talk is going to be just a quick rapid fire of a few cases where donor vessel troubles can exist and how you might choose to recognize them and then remedy the problem. The problem, generally speaking, is reestablished flow of the donor vessel. It's really not that complicated. The question is, what's going on and why is it happening? And that's really what drives the way you're going to choose to treat these problems. Those are my disclosures. So donor vessel injury can take the form of a number of different potential phenotypes, right? Dissection, plaque disruption, air embolus, thrombosis, etc. The problem is that when you have donor vessel injury, you fundamentally have a double jeopardy infarct in CTO-PCI. You have the vessel that's giving collateralization to a large territory, with the large territory of the CTO already out. As a result, you have multiple territories at risk, multiple territories that are ischemic, and that is why a lot of these patients that end up entering in period hemodynamics instability or hemodynamic embarrassment that requires very quick thinking and treatment. So, what leads to these problems? Well, there's a lot of things going on in CTO-PCI. Everything from making sure that you're watching flushing of the guide catheter to antegrade injections to your guide catheter position to obviously gear movement in the corners becomes important. But in general, what we do in CTO-PCI is try to establish support. And as a result, big guide catheters are used, and these guide catheters are often deep-seated or extended with the use of guide extension. And this can increase the likelihood of reducing flow down donor vessels, leading to stasis of blood, clot, or injury to the blood vessel wall, leading to dissection, intramural hematoma, and thrombus formation. There's also the disruption of donor vessel disease that sometimes we can't see on angiography because it's circumferential disease, or it's smooth wall disease where it's really not all that apparent. And then of course during sternalization, and then in particular during withdrawal of retrograde here, we can have donor vessel dissection as a result of sucking in of the donor vessel valves. And then thrombus and air embolism can often occur because in long procedures it's very easy to let the ACT fall below 350, and it's very easy to not to notice pressure dampening during the course of these complex procedures because your eyes are focused elsewhere. And that's one of the reasons why we now advocate that particularly complex procedures and complex CTOs are done with multiple operators. Co-scrubbing is encouraged so that you have two sets of eyes and two sets of brains looking at the same set of variables to make sure that nothing gets missed. So, in general, when donor vessel injury occurs, it doesn't matter where you are in the CTO, unless you have a complication and effect on that side, stop working and address the donor vessel injury, because that is the patient's biggest threat to life at that time. So here's a quick case. This is a 49-year-old the usual cardiac risk factors, class 3 angina, referred by his cardiologist for an exercise nuclear stress test in the presence of medical therapy that was outstripped by his symptoms. This was the diagnostic. I think it's pretty easy to figure out where the problem is, right? The LAD is a chronic total occlusion. It's filled largely by left-to-left collaterals in this picture, but then here you see that there's some pretty good right-to-left collaterals out of the PDA and into the septum. So we'll set up this case as you would ordinarily. 2 guide catheters, 1 on each side. You can do radial femoral, you can do femoral, femoral, radial, radial. At my center, we typically do radial femoral, but we have some experience with biradial as well. I like the integrity of my back, which is why I avoid doing biradial. That's just my opinion though. So in this case,